Hi, everyone. I'm Kenneth Lee, and welcome to another edition of Anesthesia DDS, where we talk about all things anesthesia and how it relates to dentistry. Today, I have a guest. His name is Dr. Sunil Patel. A little bit about Dr. Patel. First and foremost, the most important thing is that we work together, and he's just a terrific anesthesia provider, the nicest guy you'll ever meet, and just incredibly smart, incredibly gifted. Second thing you want to know is that his golf game is a lot better after a few cocktails. So just in case you take him out for a round, make sure he's got a few cocktails. He is a diplomat of the American Dental Board of Anesthesiology, and he's been working with me now for 7 years. Would you like to talk a little bit about your credentials? Tell us a little bit about yourself.
Sure. So born and raised in Los Angeles, California. Went to high school in the Valley, then went to UCLA, a couple of years there, and then decided to go to USC. I got a master's in global medicine and public health, and then off to dental school. That's where I met you. It's been about 10 years now since I graduated. So after that, I was a student of Dr. Lee's at his office, and then I can't thank you enough for all of the guidance and support over the years, but you're one of the people, definitely key person in my life that got me onto this path.
Ditto.
Yeah. So then following as a student, I was a resident of NYU, came in as a resident. And then after finishing residency, I came back to LA. And then, there's only one place I wanted to work. So
well, we appreciate that. I appreciate it. And talk to me about your involvement with ASDA, ADBA.
Mm-hmm. Yeah. So I am a diplomat of the ADBA. I'm currently on the board as well for the written exam, where we create the questions and stuff like that for that as well. We also go to ASDA, and Dr. Lee does lecturing there as well. And I've done a couple of lecturing, especially for the assistant course.
Great. Well, welcome to the podcast. Today's topic is sedative agents, anesthetic agents. We're going to talk about different drugs, how they relate to different providers in dentistry, what are some important key concepts about these drugs. So we'll get right to it.
Mm-hmm.
Let's talk about drugs that have every drug has a therapeutic range. Certain drugs have a wider margin of safety.
Mm-hmm.
Those are drugs that are more conducive to moderate sedation. Talk to me about what you think about margin of safety, therapeutic range. Can you define those for us? What are your thoughts when we talk about that?
Sure. So therapeutic range is like the minimum dosage or plasma concentration a drug would need to be to achieve a certain level of desired effect. That goes up to the maximum therapeutic range, and after you exceed that, you kind of get into that overdosing kind of.
So every drug has that range, which
mm-hmm.
is dependent upon its individual structure. Doesn't necessarily mean that just because it's in the same class, it
mm-hmm.
has the same therapeutic range.
Mm-hmm.
What makes a drug safer versus not as safe?
So a safer drug would have a wide therapeutic range. So it's so an analogy is like, the game cornhole.
Yes.
Okay. So you're
not
trying,
very good at it.
Yeah. So you're trying to toss this beanbag into the hole. The therapeutic range is, you just want to get that beanbag into the hole. If you're too short, you're not going to be on the board. If you're too long, you're going to be off the board. You kind of want to be on the board or ideally in the hole. So drugs that have a wider therapeutic range are going to be, it's like playing that game with a larger board. It's going to be easier for yourself to get that beanbag on the board or into the hole. Drugs that have a smaller therapeutic range are going to be a little bit more difficult. It's much more easily to overshoot or undershoot. So it's going to be more difficult to titrate that perfect amount.
Got it. And that relates to safety as well.
Yes, exactly.
Great. So the drugs that we use mostly for moderate sedation, say midazolam,
mm-hmm.
That has a very wide therapeutic range. So in your analogy, using part of your analogy is that I can give a little bit of drug and it has an effect. I can continue to give more and it doesn't really reach the toxic levels.
Yeah.
So a good drug for those of us that are doing moderate sedation
mm-hmm.
because of the margin of safety.
Especially if you're going to be bolusing as well. So as you bolus, you're going to have peaks and valleys. So you want that larger bore, that bigger therapeutic range so that you can stay within those parameters. If you have a tighter range, it's going to be much harder for you to bolus. So if you're using a bolus technique, then versus like a continuous infusion or an inhalational, like say with nitrous, to achieve that, because it's going to be less titratable.
So, and I just want to clarify, when Dr. Patel means bolus, what we're talking about is giving 1 milligram, still titrated, still try to titrate it to effect, but we're giving a 1 milligram bolus over time, or that 1 milligram over a minute. So that's to differentiate as a continuous infusion where we're using an infusion pump. So don't interpret when we say bolus as we're giving 5 milligrams at a time. No, we're giving a titrated portion over time.
Yes.
But it is not through an infusion pump. And we already talked about the different techniques that we can do, right? We can do inhalation, continuous infusion in an infusion pump, and intermittent bolus. And so what would be the advantage? What are you trying to achieve with drug administration? What would be the goal for use? If you were telling a student, hey, this is midazolam, and we're trying to give this, and we're going to have like a 2-hour procedure. What are some goals that you think would be ideal for that drug administration?
Perfect. So it's depending on the type of anesthesia that you're trying to achieve. So if you're trying to achieve like a moderate level sedation, there's definitions of what it means to be in a moderate level of sedation. So that would be to be responsive to, a stimulus, a mild stimulus, tactile or verbal or what's not. It would not be accurate to say that you would be under moderate anesthesia if you required like a painful stimulus or something like that. So when we say we want to be in that specific range, we want to be in the range that defines the anesthesia that we're aiming for.
So ideally, when we're giving these medications, we would want the drug to be given over time, and we want to be able to administer drugs so that we minimize the peaks and valleys. And I think that's one advantage of a continuous infusion, is that we're administering continuously, just like we would with, say, nitrous oxide. That's one of the ways that we could administer continuously. And when we talk about midazolam, it's of the class benzodiazepines. So what are possibly some other drugs that could be used in the benzodiazepine class?
Typically, benzos, there's a couple of different benzos that you could use. A lot of them are given parenterally, so you can do an oral or even a rectal in case of like an emergency midazolam for status epilepticus. But for our purpose, if we're using it for more of a sedation, then we're going to give it as an oral medication that's going to go through a first pass metabolism and then be available to the body to make its effects on the GABA receptors. GABA is like the inhibitory neurotransmitter that's going to provide that sedative effect. But we can also give it IV as well. Like midazolam can be given IV. But that's typically those are the routes that are given.
Okay. So when we give the other drugs that we could use, diazepam, remimazolam, which is a new drug that we can talk about. All these drugs are benzodiazepines. Benzodiazepines are great because they provide us with a lot of effects. First and foremost, they produce amnesia. They generally produce predictable amnesia following drug administration. And it's the loss of ability to create these new memories, which, for dentistry, if you have a patient that is fearful, anxious, one of the things that they don't want to do is remember the procedure. There's some other effects that benzodiazepines can give.
You're also going to have a little bit of that sedative effect.
Okay.
You may have some respiratory depression, even though that it could be what you're looking for, but you may have a little bit of respiratory depression, but you're also going to get that amnestic effect. It's probably the most important thing, the anxiolysis and that amnestic effect.
And with benzodiazepines, one of the questions that I ask in a pre-op is how patients respond to alcohol, because alcohol can be a disinhibitor. Benzodiazepines can also disinhibit. So think about the Super Bowl party that you're going to have. You're going to invite 10 friends to your Super Bowl party. Some of them are going to get a little disinhibited. And when they do they get angry? Do they get talkative? So those are things that we need to ask before we administer these drugs, because benzodiazepines do produce a disinhibition.
Mhm.
They also can produce a mild skeletal muscle relaxation. So your patient that can be tense and nervous, well, they're going to be sedated with an anxiolytic. They'll also have some skeletal muscle relaxation to help them rest a little bit better so that we can do our dentistry. With benzodiazepines, so we're going to have minimal respiratory depression. That's a good thing, right? So, and also the prevention and treatment of seizures. So let's talk about what makes them different. So, midazolam, is it the ideal drug? Does it produce any analgesia?
Analgesic, not as much. That's why we're going to use for moderate sedation, especially we're going to use like opioids. You can use a little bit of nitrous that provides a little bit of analgesia, but for the most part, your benzodiazepines are not going to be your go-to for analgesia. But it's going to produce.
Does it have, what about post-operative nausea and vomiting? Do we have post-operative nausea and vomiting with?
No, and not, yeah. So you're not going to get, that's a good thing about the midazolams or the benzodiazepines, not going to produce a lot of that emetic effect. So not as, say, like an opioid would.
So we're going to get anxiolysis, we're going to get sedation, we're going to get amnesia. These drugs, benzodiazepines like midazolam, work pretty quickly, right? They work, so if they work quickly, how are we titrating that? What are we doing to make sure that we're not giving too much?
We always titrate to effect. So we're going to give a bolus, say for midazolam, if we're doing an IV bolus of midazolam, we're going to give 1 milligram per minute up till your desired effect. And that depends on the depth of the anesthesia you're trying to see. So if you're trying to achieve that moderate, and you're going to administer it 1 milligram per minute until you start to feel like the patient's a little bit more relaxed, more calm, more comfortable. They may doze off, but that's not like a requirement of moderate sedation, but they should always be fully arousable.
Yeah, so when we talk to patients about moderate sedation, we talk to them that they'll be more relaxed, right? They won't fall asleep if they may become so relaxed that they do fall asleep. But yeah, we definitely don't want them to feel like they are falling asleep. And that peak effect generally occurs very quickly in about 3 to 5 minutes. A drug like midazolam, how often would we have to re-administer?
So
when would we re-administer?
When you would re-administer when you feel like the patient is out of that therapeutic range. So if you give the drug and then over time the body is able to metabolize
so
that.
How would I know if they're out of that therapy? What sorts of things would they
So if they become more fidgety, more talkative, they are more alert and oriented, and you're not able to proceed with your dental procedure as expected, then they may be underdosed or coming out of that therapeutic range.
And then we would just give them the same amount that we gave before?
No, always titrate again to the effect that you're trying to achieve.
All right.
So it may not be the same dose because there's going to be some drug that's still available into the body. So we just need to make sure that we get that plasma concentration back into that therapeutic range, but it may not necessarily be the same exact dose.
And for midazolam, we're going to have some amnesia. The amnesia generally 30 to 45 minutes after administration. So if we're looking for amnesia, then certainly we want to re-administer another titrated dose sometime in that 30-minute range.
Exactly.
And typically, I know it's very difficult to say for every patient, but in the experiences that you've had, what's the general dose what is the general range of dosages for, when would we know, hey, this drug is working versus we need to try something else?
So usually 5 milligrams, that usually takes care of most people, that ED95 kind of range there.
5 milligrams over 5 minutes?
Over 5 minutes, yes. But everybody's different. And like you said before, the analogy of like you're at the Super Bowl party, that drug may be a disinhibitor. So you may be giving a drug and getting an opposite effect that you like. You may be getting more of the talkative drug than the relaxed drug, right? So you have to kind of gauge whether or not this is the same right
Don't
path.
Give more alcohol to the drunk.
Exactly. You don't want to keep going down that same path because you may not like where you end up.
And then a new drug that's come out, new benzodiazepine, which we don't have too much experience with, but we've used it a little bit, is remimazolam. Can you tell us a little bit about remimazolam?
Yeah. So all the benzodiazepines, they all have like a certain half-life. It's a function of their pharmacokinetics, how fast the body is able to metabolize and get rid of that medication. But remimazolam is a little bit different. It's not passed through the liver and metabolized. It's actually metabolized by plasma esterases or tissue esterases are in the body. That so it doesn't require that first pass or that metabolism through the liver. So the half-life of that medication is much shorter. So it kind of comes on really quick, and it is able to be metabolized really quick.
So give me an idea of how long this drug is going to last.
Typically, you'll see an onset similar to the midazolam. So you may see it in that first 3 to 5 minutes, but then after you discontinue it, it should wear off within a relatively short amount of time, about 5-10 minutes.
So if we give remimazolam as a single dose, you'd expect it to be gone in 4 or 5 minutes?
Yeah.
Yeah. So, which is different from midazolam, which is a little bit longer. And when we give this drug, are we working on the same receptors other than the tissue esterases? Is there anything different about it at all?
Like I said, it's just to metabolize a lot faster. The structure of it is has a ester in it, so our certain enzymes in the body are able to metabolize it without having to go through the liver and the cytochrome P450 pathway.
And right now, I believe that the FDA approval is for intermittent bolus administration. On a drug like this, I would think that would be very difficult.
Yeah, because you're going to, especially, so there's on the actual label, it does specify that it may not be suitable for operating anesthetists. It's more like to be given as a independent provider, because you're probably going to be having to sit there and give it. I wouldn't want to give it as, say, if I'm doing work in the chair and then have to stop every 2 minutes, 3 minutes to have to redose.
Right. And my experience with remimazolam is that the amnesia, because it goes away so quickly, if you're not using an infusion of remimazolam,
you're going to have those little gaps.
You'll have those gaps where patients will remember. So it is a little bit rapid onset as opposed to midazolam. It definitely goes away faster, but is a lot trickier to use. And really with this drug, I find that it's going to have fairly minimal effect in the dental community because of that rapid utilization of the drug and that requiring an infusion pump most likely, and also because of the operator anesthetist package insert description. But there is quite a lot of literature that it is very effective. The main difference is that comes on faster, goes away a lot faster. Very expensive drug, may not be the perfect drug for you. Midazolam works quite nicely, but certainly something that will need a little bit more investigation.
Yeah. Relatively new type of drug, so more research is going to go into it, and eventually, when it's off of patent, then maybe it'll be more available in terms of the financial aspect.
Cost per hour is definitely going to be more expensive. If you're using midazolam, you're probably using maybe $3 or $4. Remimazolam is going to be about $100, $125 per hour of usage. So just another thing to consider. So that's the primary drug that we use for most moderate sedations. Even when we're doing a general anesthetic, oftentimes we use a benzodiazepine.
Sure.
Let's talk a little bit about another class of drugs, and we might have a future podcast where we're talking specifically about all these individual agents, but opioids, opioid agonists that we utilize in dental anesthesia. Fentanyl, which most of you are familiar with, sufentanil, meperidine, hydromorphone, and for GA providers, remifentanil.
Yes.
Can you tell us a little bit about the what is an opioid? What does it do? What are the differences that it has here?
So the opioid, if you take the root word from it, it comes from opium, from the poppy seed, and it is an agonist for opioid receptors that are naturally found in your body, and it binds to those different types of opioid receptors and kind of gives you the effects of the analgesic effect as well as the respiratory depression that goes along with it, or the GI issues that you can have with it.
So you talked about receptors. Do we have one receptor for opioids?
No, there's a couple of different ones. Primarily, you're going to be talking about the mu, but you also have the delta and the kappa.
And we have, you mentioned that we have some endogenous ligands.
Yeah.
So in the mu receptor, I believe it's the beta enkephalin, and delta is delta and kappa also have some as well. So what are some of the effects that we're looking for with an opioid? Why are we using an opioid?
Typically, we're using the opioid for that analgesic effect.
Okay.
Yeah. So that's the primary role of the opioid is the reducing that pain threshold. But does have other side effects as well, as including shifting that CO2 response curve and causing respiratory depression.
And does it block pain? Does it help modulate? What?
It kind of doesn't necessarily block those pain pathways, but it kind of makes it so that you are not as stimulated by them.
Okay. And then some of the other effects or side effects?
Using certain types of opioids at a higher concentration can lead to things like chest wall rigidity, but it's more of using them at high doses.
Okay, so chest wall rigidity, that's certainly a topic that we're going to talk about in a little bit, but in terms of the respiratory system, we get respiratory depression.
Yes.
So that could be a good thing.
Yeah.
That could be a bad thing.
Yeah.
Basically, describe what we're seeing with respiratory depression. How are opioids depressing our respiratory centers?
So in our body, we have something, it's a physiological effect called the CO2 response curve. So normally our body has a set rhythm depending on the tidal volume that you breathe, like how much you breathe per breath, and how many times you're breathing per minute. And it wants to keep that CO2 within a certain range. Normally it's going to be, your CO2 is going to be about 40 plus or minus 5. And that's going to help keep the pH of your body within a specific range. And that specific range is crucial because we need to keep certain enzymes in that pH range so that they're most effective. When we administer an opioid, it's going to shift that CO2 response curve so that the body is trying to maintain a different level of that CO2. And that's what causes that respiratory depression, because now instead of the body saying, I need to breathe this many times per minute to keep me at 40, it's blunted. So now it's saying, okay, instead of 10, we're going to breathe at 6 times a minute, and that CO2 is going to be higher.
So our drive to breathe, which we can measure with CO2, but primarily is pH.
Yeah.
We need a higher pH.
Yes.
We need we need a higher level of CO2.
Yes.
For
Which would
the
be
body
a lower
to
pH. Yes.
for the bodies to stimulate breathing.
Yeah.
And we talked about, you mentioned chest wall rigidity. So talk to me about why this is important and when we would tend to see chest wall rigidity.
So it happens more so in specific opioids versus others. So if you're using fentanyl, a lot of fentanyl, then you're going to see that more than if you're using, say, other opioids like hydromorphone or per se. But what's going to be difficult is the patient's inability to breathe and be able to expand their diaphragm and their ribs to be able to adequately produce enough negative pressure to take an inhalational breath.
And we know this doesn't affect the skeletal muscle.
No.
It affects the nerve itself.
Yes.
Although the mechanism might be a little bit unknown. And how would we treat that if you administered too much fentanyl or too much remifentanil and the patient wasn't able to breathe, you weren't able to ventilate a patient? How would you treat that?
The first thing would 100% oxygen. And then you may need some positive pressure ventilation, and then you may need to reverse. We can't
positive pressure ventilate.
Yeah.
So how would we get over this? How would a provider?
You can use a reversal agent, say naloxone,
Okay.
Yeah.
Yep. So that'll take care of that 100%.
Yeah.
Great. Great. And then if you're a GA provider, simply neuromuscular blockade,
Yeah.
succinylcholine.
If you have the ability to paralyze a patient, then that would be helpful as well. And then you would be able to
And
ventilate,
chest wall
positive
rigidity,
pressure.
this is something that I've seen happen in as little as 75 micrograms on a patient. Happened to be an elderly patient.
Yeah.
And we used succinylcholine and was able to ventilate that. But again, one of the side effects that are very important to be able to diagnose and for moderate sedation provider, treat with naloxone.
Mm-hmm.
How do we prevent this? Small incremental doses.
Yeah, and every patient's going to be different. It's important that you mentioned like the age of the patients as well too, because we have that therapeutic range, but that is going to be different for every patient. You're not going to use the same kind of dosages on every patient. Everybody's going to be different, and especially with our older population or anybody with like say liver disease, if they don't produce as many of those plasma proteins, then there's going to be increased bioavailability, especially for those benzos and those opioids.
Great, great. And let's talk about some of the other physiological effects. We're using opioids primarily for analgesia. Everything that we do in dentistry requires some analgesia. You can argue that local anesthesia helps with that, obviously, and not everyone would use an opioid. But there are some things that we specifically look for with physiologic effects to the cardiovascular system. So what are some of those effects?
So you're also typically going to see a decrease in the heart rate and the blood pressure as well. So your cardiovascular system is typically going to become more relaxed as well.
So not always a bad thing, right?
Yeah.
Cardiac patient, we do want a decreased heart rate. Then again, if we start off with a patient with a heart rate of 50, maybe not the choice
exactly
for that. And typically that heart rate response is mediated by the vagus nerve, correct?
Yes, exactly.
Except with meperidine, we can increase the heart rate.
Right. So meperidine has a specific structure. It's very similar to atropine. And we know atropine, this anticholinergic, is going to help increase the heart rate. So sometimes you may see that increase in heart rate when you administer the meperidine.
And then cardiovascular system vasodilation could decrease in blood pressure, increase in blood pressure. What can we find?
You would expect a decrease in that blood pressure.
Okay, and it's reduced cardiac output.
Yeah,
basically. So again, very useful in patients that may have cardiovascular disease.
And the elderly as well. We were talking about like the decrease in the blood pressure and the heart rate. You may see some orthostatic hypotension as well. So be aware of using that drug, and then having the patient sit up quickly can cause some syncope as well.
And I think one thing that gets a little bit underestimated with opioids is the euphoric effect. So if we're providing analgesia, some somnolence, there's also the euphoric effect where a patient, even though the pain is still there, they really don't care that it's there. And so that helps reduce dosages of other things,
medications
of
as well.
The other medications as well. So we do have a lot of nice effects with opioids and some side effects, primarily being respiratory depression. Let's talk about the different opioids. Let's start off with fentanyl.
Okay.
So tell me a little bit about fentanyl.
So fentanyl is a synthetic opioid. Relative potency of about like 100 times morphine. So in the literature, everything is referenced more closely to morphine. So everything has a relative.
So isn't that dangerous? 100 times more potent than morphine?
Yes, but we also give it at an equal potential dose. So we don't necessarily give the same dosages. So say if it's 100 times more potent, we just give 100 times less of the drug.
And specifically with fentanyl, tell me how long you'd expect it to last. What sort of time frame before it starts working?
So typically you'll see the onset about 2 to 3 minutes, maybe a little bit less, but peak effect. And then it will typically last about 30 minutes up to an hour, depending on the patient.
And talk to me about context-sensitive half-life then. This is an important topic as we're talking about fentanyl in particular. but other opioids as well. Let's talk about context-sensitive half-life. It's a half-life that is unique to each drug, can't be predicted with any other half-life. Can you tell me about context-sensitive half-life? What is it?
So specifically when we're infusing medications, every medication is going to have that context-sensitive half-life. It's the amount of time that it's going to be required, and it's dependent on the duration of the infusion that you gave.
So if we give a drug for a certain period of time, this is the half-life that reflects what?
The duration of time till it is eliminated from the body.
Reduced by 50%.
50%, yeah.
And
fentanyl is specific in that it has a very high context-sensitive half-life. So if we did choose to infuse it, it would take a much longer time for us to
So the longer that we infuse fentanyl,
yes,
the longer it takes for the drug to reduce by 50%.
Yes.
In particular with fentanyl, it doesn't take long before that curve accelerates very quickly. So when when fentanyl, for example, is infused for, say, 30 minutes, it takes about 30 minutes for it to be reduced by 50%.
Yeah.
But if it's infused for 2 hours, it takes longer than 2 hours.
Yes, exactly.
So
kind of exponential at that point.
And that's probably the worst thing about fentanyl is that if you're using a lot of it, it doesn't have to be just an infusion.
No.
But if you're using a lot of fentanyl over the course of the case, it's going to stick around in the body. Where does it go?
So there's a distribution and redistribution depending on the structure of the medication and how lipophilic it is. It likes to hide in the tissues. So fentanyl being one of the ones that likes to find its way into adipose tissue or other tissues. And then even after we remove the infusion, it will slowly kind of seep out of those tissues back into the circulation.
And fentanyl, notorious because it has so much bound in the tissues, when you stop using the drug or when you dismiss the patient, it's still with shivering, with movement, it's released from the muscles, it's stored in the lungs. So we can have a prolonged respiratory depression even after discharge.
Exactly.
And that's the worst thing about fentanyl. Duration of action of fentanyl is about 30 minutes, right? So have to redose after 30 minutes. What about another drug, meperidine? Can you tell me a little bit about meperidine?
Yeah, we kind of mentioned it before. It's like structure-wise a little bit more similar to the atropine. So you can have some of that increase in the heart rate, which makes that kind of unique. In terms of potency, it's going to be less than, say, morphine. So it's not going to be as strong, but it's going to give you that very nice euphoric effect. So we kind of use it a lot for that euphoria that you get without causing a lot of that respiratory depression as well.
So when we're using euphoria, you're using it for small doses. I think the duration is 30 to 45 minutes. Analgesic duration could be 2 to 3 hours, and onset within a few minutes. And it produces probably the most intense euphoria over most of the other drugs. A lot of, refer to it as a dirty drug, meperidine, because of some of the metabolites. Are there active metabolites?
Yeah, it's exactly. So you're going to have that first pass, and then you're going to have some of that drug still active. So specifically the normeperidine, that's going to be that active metabolite.
And some other effects of meperidine, we talked about anticholinergic effects, and we do sometimes get a histamine release. Is that an allergy to the drug?
Not necessarily. So you'll see that with morphine as well. So when you give morphine or meperidine, sometimes with hydromorphone as well, but mostly you're going to see it with meperidine or morphine, but you're going to get that histamine release. So you'll see maybe redness in the arm or tracking in the arm at the IV site, which you give it. It's just it's a side effect of the drug itself, but not necessarily an allergy.
So we don't have to treat that with Benadryl. The patient's not allergic to it.
Yeah, it'll go away with time.
Okay. You mentioned hydromorphone. So we've got two shorter acting drugs that we've talked about, fentanyl Also talked about meperidine, which is a 30, 45, 1-hour drug. Let's talk about hydromorphone, Dilaudid. When would we use Dilaudid? How does it relate to potency and so on with as a relation to the other drugs?
Yeah. So hydromorphone is going to be a longer acting, about 2 to 3 hour duration, but its a potency is going to be, say, less than that of fentanyl. Instead of the 10 times, 100 times that you get with fentanyl or sufentanil, you're looking more about a 5 to 10 times range. So it's
over morphine.
Over morphine, yes. So you're giving that as kind of a good base of analgesia that's going to provide you with a longer kind of tail of anesthesia or analgesia, I should say, versus having to give, say, fentanyl in repeated doses.
And these drugs are all related, right? They all produce some respiratory depression, but they're like cousins. You know, when we go to every city, Sunil, you have a cousin.
I do. A lot of cousins.
Every city we go to a meeting, we go play golf. I'm going to go visit my cousin.
Yeah.
So you're all related.
Yeah.
Just like the opioids are, but you're not the same.
No,
right?
Definitely.
You each has its own characteristics. And one of the characteristics of hydromorphone is that its potential to cause respiratory depression is much less than fentanyl.
Yes.
So when we have a drug like that, even though it's a longer lasting drug, it seems to be that it would be a better option for us to use if we want our patients to continue to breathe spontaneously. Every drug has respiratory depression. Every opioid has respiratory depression, but with Dilaudid, we have less of a tendency towards that. So a great drug to use for a 2 to 3 hour case, especially, again, if we want the patient to be spontaneous. And how does it come? Are there different formulations? And how would we use this?
So it can come in different concentrations. So you have to be comfortable with the concentration that you get. You're just typically going to be a 1 milligram per ml, 2 milligrams, or 10. And so those dosages, especially at that 10, is going to be exceeding that therapeutic range, right? So we're going to need to know how to dilute that medication into a more appropriate level to give. So
how much are we giving per dose? How many milligrams are we giving if we're doing a moderate sedation? What is our typical dosage that we would give?
Typically, I'd go with 0.25 to 0.5 bolus at a time, and then wait about 10-15 minutes because that peak onset, that onset is going to be a little bit slower. So although it's a longer lasting medication, it doesn't have that same onset time as, say, of those shorting acting medications. So I would wait at least at 10-15 minutes before you give it another dose.
And I think the peak effect of that drug is at about 15 minutes, right? So if the peak effect is 15, if we need to give more, we could give more at that point.
At that point, yeah.
And we'd still have 2 or 3 hours of analgesia with that. Okay, so final drug we're going to talk about today is my favorite drug, which is sufentanil. Now, this is a drug that most of us in dental anesthesia are not accustomed to using, maybe not even heard of it before. Talk to me about sufentanil. How does it relate to duration of action, potency, when you compare it to its cousin fentanyl?
So onset time is going to be about a minute, slightly slower than the fentanyl, but it is more potent. So instead of typically our fentanyl doses, we're giving 50 mics at a time. We're normally giving sufentanil as a bolus 5 mics at a time.
It's more potent. Is that more dangerous?
So it has, because of its structure, it has a really high affinity for that mu opioid receptor. So it has it has a little bit wider therapeutic range or therapeutic index of fentanyl, and it has a little bit less respiratory depression than fentanyl. So you can still get like kind of the best of both worlds. You can get really good analgesic effect, but it's not going to produce as much respiratory depression as the fentanyl would.
In fact, in a comparison of fentanyl and sufentanil in different studies, we find that sufentanil has a higher therapeutic index, like you mentioned, has less respiratory depressant properties. So again, a great drug that we're going to use for moderate sedation if we're looking for patients to be spontaneously breathing. Even for general anesthesia, if we want them to be spontaneously breathing, sufentanil seems to be the better choice. It does also, which is great, have a lower incidence of postoperative nausea and vomiting. So there's different studies out there that have showed that. So a wonderful drug in terms of its relation to fentanyl. But how does it come? How do we dilute it? What are we doing?
Yeah, that's probably one of the more difficult things. The first time I used sufentanil was actually at your office. It's not a drug that's widely used in a hospital-based kind of setting, more so in our little private world, but it's still a great drug. It comes in a 50 mic per ml, either as a single dose vial or as an ampule of 5 milliliters, so 250 micrograms.
So the concentration is the same as fentanyl, 50 micrograms per ml when it comes.
Yeah.
But it's 10 times more potent.
Yes.
So
which is why we have to
10 times less.
Exactly. We have to be careful. We have to make sure that our dilutions are accurate so that we're giving the correct equal potent dose.
So what would be, you think, the easiest way to dilute that? If we're going to use sufentanil and we don't want to use it obviously at 50 mics per ml, what would be the easiest way to dilute that?
So if you have a vial that says it has 1 ml in it, and 1 ml is 50 micrograms per that 1 ml, and we're trying to achieve 5 microgram per ml, there's going to be a 1/10 dilution. So for me, I think the easiest thing for me to do is take 9 cc's of any diluent, and then just draw up that last cc of that sufentanil. So we're putting the 50 mics in a total volume of 10 micrograms, which would give us that 5 microgram.
Okay. And again, we want to use 2.5 to 5 micrograms.
Yes, so half a cc or 1 cc at a time. One
of the wonderful things about sufentanil that I found is that the magnitude and the duration of the respiratory depression was much less. Dr. Ken Reed, many of you know Dr. Ken Reed, when he worked at Solus, where Sunil and I work, he did these opioid trials, which we were a part of. And basically what he did was administer equipotent dosages of opioids, fentanyl, remifentanil, sufentanil, hydromorphone, meperidine, on patients that were going to be or already intubated general anesthetics. And what we found is that when we gave boluses of sufentanil and hydromorphone, equipotent dosages compared to fentanyl, we had much less respiratory depression. And some of those patients would not even get apneic with the equipotent dose of 50 or 100 micrograms of fentanyl. So we have a drug that produces less respiratory depression, certainly a safer drug in that regard, less postoperative nausea and vomiting. But really the key here is that we have to dilute this drug and learn how to use this drug. But otherwise, a great drug with excellent context-sensitive half-life. You can administer this drug for a few hours and only have a 20-minute context-sensitive half-life, as opposed to fentanyl, which would be at least a few hours with its context-sensitive half-life and less postoperative nausea and vomiting. So that's all we have time for today. Talked about midazolam and the benzodiazepines and opioids. Looking forward to our next conversation with more sedative drugs. Thank you, Dr. Patel.
Of course.
And we'll see you here at the next episode of Anesthesia DDS. Thanks for joining us.